Guys, my name is Shawnee Alvarez, and I'm just going to go ahead and introduce you to my article. And what we'll be looking at today is a cross-sectional study of the microeconomic impact of cardiovascular disease hospitalization in 4 low and middle income countries. There's a ton of authors here. Mark D. Huffman is probably the most important one because he's listed first. And this article in particular was published in the Public Library of Science, which that's what the PLOS stands for, 1. And it was published in June 2011, and it can be found in Volume 6, Issue 6. So basically, this article, it wants to look at, or rather estimate, individual and household economic impact in selected low and middle income countries. So how they introduced it was that cardiovascular disease is the leading cause of mortality and among the leading causes of morbidity worldwide. So it also talked about how on average cardiovascular disease affects patients in low and middle income countries 10 to 15 years earlier than a high income country. So it reduces workforce capacity and potential economic growth. And this why I decided to look at this, it was particularly interesting because in my introduction I talked about how I wanted to go into nursing, but right now I'm a pharmacy technician, and while I'm not, in a clinical setting, I've seen the magnitude of cardiovascular disease within my job almost every day. So even just the output of the drugs that we distribute to combat this condition or related chronic conditions has piqued my interest in a medical field in particular. So I've just seen how the expense of the drugs, even with insurance, is one thing, but hospitalization is just a whole other spectrum. This article doesn't look at the United States, and just kind of like a background, heart disease is like the #1 killer in the United States, accounting for 1 in every 3 deaths and nearly affecting 1 in every fourth person here. And just with that, I believe just the direct and indirect cost of cardiovascular disease in the U.S. is estimated to total more than $316 billion. So that's just here. And while we're not a particularly low-income country, it's really interesting to see how this affects countries such as this that may not have, the benefits that our country offers. So the 4 countries that they decided to look at was India, China, Tanzania, and they also looked at Argentina. So what they're trying to look at is evaluating an acute cardiovascular disease event, meaning just a hospitalization, on their economic impact in the household. So they actually conducted a survey in these 4 countries that I mentioned before to quantify that effect for that event on healthcare expenditures, how people finance those expenditures, impoverishment, and changes in functional capacity and productivity. So what they hypothesized is that a cardiovascular disease event in a family member would produce a higher effect on family financial stress in low-income families and families without health insurance. So, like mentioned before, it's just a cross-sectional study. They chose 3 to 7 hospitals, a mix of public, private, urban, and rural, to get kind of a very representative sample of what they're trying to look at. So, what's important is that all decisions related to in-hospital and follow-up medical care were decided by the participant and his or her providing physician. So, additionally, what was really nice about this article, and I really appreciated, is they defined what these terms that they used throughout the article. So household health spending was considered catastrophic, and it'll be referred to as catastrophic health spending later on. They defined it as catastrophic if annual out-of-pocket health expenditures were equal to or greater than 40% of total non-food household expenditures, since that spending is likely to result in impoverishment in another aspect of their life. Additionally, they also use the term distress financing, defined as borrowing money from relatives, friends, taking loans out, selling assets in order to pay for that recent hospitalization. So most of the patients, they were about 53 years to 59 years. In China, the ages vary considerably across the countries. But then they also started to break down they also broke these participants down by their socioeconomic status. So they looked at low, middle, and high income residents within each country. So there was 16 different groups that they were looking at how these expenditures affected their household. So, for example, they looked at 15th month out-of-pocket cardiovascular disease health spending. So, from their hospitalization point, they looked at 15 months thereafter to see how much was spent within that period. So, for example, in the median 15th month out-of-pocket cardiovascular disease health spending ranged from $374 in the low-income group in Tanzania. So they just broke that down for each group. And they didn't specify, they didn't go down, one by one. They kind of just generalized what they thought was more important. So, for example, out-of-pocket cardiovascular disease expenditures were significantly higher in high-income strata in India and Tanzania, but significantly lower in the high-income group in China. Additionally, participants from all countries and all income strata reported a decrease in individual incomes after a cardiovascular disease event. Especially those from low-income strata, they were more likely to report a decrease in individual income than those in a high-income stratum, as expected. So, as I mentioned, the catastrophic health spending, they're going to refer it to CHS. It occurred in all countries and income strata. And while the range is pretty wide, 5% in Argentina, 92% to 92% in India and Tanzania, it still occurred. And additionally, the distress financing ranged from 1% in Argentina, but that's in the high income stratum, to 64% in India, which is the low income strata. So the distribution of how these families decided to implement distress financing most definitely differed across countries. They also accounted for if these individuals had any private social health insurance, and it appeared that in India, health insurance was the strongest predictor of avoiding distress financing. And then they started to break it down by country, which I really appreciated. That the article, it was a lot more organized rather than going back and forth and comparing and contrasting within each sentence. It was really interesting to see what they found by country, and then talking about what if that was similar in comparison to other countries. So I won't go into detail with all of them, but just a couple sentences that stuck out to me was in Argentina, the 15th month out-of-pocket cardiovascular disease expenditures were similar across all income strata, with a trend toward increased costs in the high-income group. This group had the highest amount of coverage, of health insurance coverage, and what was really interesting to me is access to ambulatory and hospital care is fully granted for all of their citizens, regardless of their status or not. And this definitely did not deem true for these other countries that they looked at. And their catastrophic health spending was relatively low across all groups, but significantly associated with the lack of health insurance. And distress financing wasn't quite significant among any of the income groups that they looked at. So with China, the overall out-of-pocket cardiovascular disease expenditures were higher among participants in the low-income stratum, which is obviously expected. So the catastrophic health spending was also highest in the low-income stratum. They also saw similar distribution with distress financing associated with the low-income group, and most often they are found in the rural areas of the country. India had the highest 15th month out-of-pocket cardiovascular disease expenditures. Insurance coverage was actually uncommon in most of the respondents that they looked at. So they also saw something similar for distress financing, and the proportion of participants who experienced any decrease in income was highest in the low-income stratum, but the absolute decrease was also highest in the low-income group. And lastly, for Tanzania, their 15th month out-of-pocket cardiovascular disease expenditure was associated with the high-income respondents, and insurance coverage was also low throughout Tanzania. So in comparison to Argentina, China, Tanzania, and India didn't have that as high of a rate of insurance coverage. So then they looked at, so that's just an expenditure, very general term, versus they looked at functional capacity and productivity. So this is kind of looking at an indirect economic impact. So these look at, work time, work activities, and whether there was a net increase or decrease in work time to compensate for that family member's disability. So they also broke this down by country, and I thought that was really nice to look at, maybe cultural norms or how an issue like this is dealt with in the household. So in Argentina, 50% of the participants across all income strata reported a decrease in their health, with nearly all reporting a decrease in their ability to participate in moderate to vigorous activities. And then they experienced emotional problems following their hospitalization. It's about 61% here. And cost was the primary reason for not taking one's medications in a good portion of respondents. There was a decrease in work time, their work activities were limited, and the low-income group in Argentina was more likely to just feel limited overall. And I definitely won't go in depth with each country, but this trend is very, very similar. There's just a decrease, rather like their self-rated health is just depleted. They report their inability to, or rather their lack of inability to perform any physical activity or what they were able to do before that event occurred. And a lot of the reasons why they weren't able to take the medications prescribed to them after that event was due to cost. And I thought that was very interesting, because cost in my pharmacy is something that I see. It's an inhibitory factor, and it really impedes one's ability to manage their condition as they should, and then it enhances the probability of them being hospitalized later on. So there was just a common trend seen throughout each country. Decrease in work time, as you can see here in this chart, is relatively high no matter what income stratum they were in. And this is also, it's a very, very high percentage of individuals, of the participants of their study, the percentage that reported that they could not perform the work activities they felt they were able to do before. So the article just continued to talk about this, and then they discussed that while these expenditures vary, of course, throughout each income group within each country, they're still relatively high. And poorer respondents, they pay a higher proportion of income on healthcare following hospitalization. And then they talked about the financing mechanisms and the impoverishing effects. So it's going back to that catastrophic health spending. and the distress financing. So they found that catastrophic health spending was common in China, India, and Tanzania, but most strongly impacted the poorest cardiovascular diseased patients and their families, which is what they initially hypothesized. So the high proportion of catastrophic health spending, they acknowledge that it could be underestimated because there are some individuals who actually avoid medical treatment altogether due to high perceived costs, and that just means that they assume that they won't be able to afford their visits or the hospitalization in general, so they just refuse to seek treatment. And they assume that they'll have that financial insecurity, so that's why it just facilitates their diversion from going to a hospital. And they also, one of the most important points that I saw that along with these high cardiovascular disease related costs, many participants reported decreased income, poor perceived health, lower functional and productivity capacity, and all of which exacerbated their financial instability. So the economic impact, both direct and indirect, is pretty substantial, and it's felt, following this hospitalization event. And it's just kind of a domino effect, and it'll continue to happen without adequate care. And they didn't really talk about the lack of private social health insurance, which is definitely a problem in the U.S. They did acknowledge that it does lead to an increased risk of catastrophic health spending, especially in 3 of the 4 countries, so particularly China. But they mentioned that insurance just does not protect fully against catastrophic health spending, and I think that's a really important point to make. Insurance, while helpful, it won't necessarily cover all the costs necessary for you to receive the treatment that you need, and it's just there's still a high burden of spending that could come with one's insurance plan. So the limitations of their study, and I thought that they did a really good job of acknowledging their limitations, because as I was going through the article, I acknowledged some of these myself. It was a relatively small sample size, so it may not be representative of the population that they're looking at in general, but they acknowledge that, the participants from their selected hospitals within, the countries they decide to look at, they realized that they might not be generalizable to other hospitals because treatment could be very much different in other countries. But in essence, there's cultural norms and societal norms and beliefs just very differently from country to country. So while this article is especially useful for subsequent studies, it's definitely not somewhere we should end. We should continue to study these effects in other countries as well. And then they also, what this study, so most of these participants voluntarily opted to participate in the study, and that can result in some bias. And additionally, the participants that they looked at, they definitely do not account for those who avoided seeking care altogether, or even those who just didn't survive a cardiovascular diseased event. And it would be really helpful to look at, for those who did not survive an event such as the one, any just like a death or something, if there's economic impacts following that. So is it